Okay, thank you, Dr. Christ. Good evening. My name is James Shaw. I'm an orthopedic trauma surgeon in Houston, Texas. And today I'll be highlighting two cases utilizing the CurvaFix implant for percutaneous fixation of posterior pelvic ring injuries in dysmorphic patients. So first case example is a 59-year-old male who fell 20 feet from scaffolding. He was polytraumatized. He had a subdural hemorrhage, multiple rib fractures, an open left humerus fracture, and this pelvic ring injury seen on the right. Patient was neurovascularly intact on presentation. From the AP pelvis, looking at it, you can see no appreciable injury in the anterior ring, but looking on the right side posteriorly, possibly an injury. This is the open segmental humerus fracture that the patient also sustained. Axial CT scan shows that the patient has a complete right-sided sacral fracture with traversing fracture lines as highlighted by these arrows to the contralateral side. There's also a right-sided iliac crescent fracture, no appreciable injury in the front of the pelvis. And again, this patient has sacral dysmorphism. Correlating this with the 3D surface rendered image, again, the right-sided crescent injury and the oblique traversing sacral fracture. So a little bit unusual of a posterior pelvic ring injury, not that commonly seen. So to briefly look back at the literature, sacral dysmorphism occurs in approximately 40% of patients. The dysmorphic sacrum has an acute and upsloping sacral ala, which is oblique in nature, and this misshapen osteology limits your available osseous fixation pathways for your implants and makes transsacral transiliac fixation with a straight implant nearly impossible. So again, looking back at our patient, this patient's dysmorphism is not that dramatic. As you can see, there is an osseous fixation pathway for a straight implant, but probably not a very large one. Moving more caudally, there's potentially more space for, again, a straight implant, but your start and end points need to be precise, otherwise you risk extruding anteriorly or intruding into the sacral neuroforamen. So really, this patient has ample osteology for iliosacral fixation, should you choose. And so we indicated this patient for surgery and thought that this patient would be an excellent candidate for the CurvaFix implant. So here, we took the patient to the OR. We positioned them supine with a midline lumbosacral bump on an OSI flat Jackson. Here we are localizing our start point with a 2.0 millimeter Steinman pin, followed by our entry reamer, our introducer with our steerable guide rod, judiciously using biplanar fluoroscopy to navigate our steerable guide rod in the osseous corridor to the contralateral side. Here we're measuring and then over-reaming. At this point, we elected to go to the second sacral segment prior to application of the CurvaFix implant. And again, this is to assist us in our visualization of the second sacral segment and not obscure it from the larger CurvaFix implant. So we elected to apply a 7.0 millimeter straight, fully threaded cannulated screw in the second sacral segment, and the CurvaFix in the upper sacral segment. Final AP inlet and outlet fluoroscopy. So we routinely use postoperative CT scan to assess implant placement, safety, and reduction. And here you can see the CurvaFix is safe in the upper sacral segment, as well as the straight screw is safe in the second sacral segment. And then postoperative AP inlet and outlet films. In a different setting, we elected to perform ORIF of the patient's left humerus as well. Our second case highlighting the CurvaFix is a 32-year-old female who was a pedestrian struck by an automobile. She was also polytraumatized with a liver laceration, multiple rib fractures, and this pelvic ring injury. She was neurovascularly intact on presentation, and she also sustained a right clavicle fracture. This was her right distal clavicle fracture and representative AP inlet and outlet films of her sacral injury. Preoperative CT scan shows that this patient has sacral dysmorphism. She has a complete right-sided zone 2 sacral fracture and a right-sided high ramus and parasymphyseal superior ramus fracture, as well as an inferior ramus fracture. Representative 3D surface rendered imaging, again, complete right-sided sacral fracture and segmental right superior ramus fracture. So again, this patient's dysmorphism is more acute, and really there's no available osseous fixation pathway for a straight implant, at least in the upper sacral segment. But this patient does have ample room for iliosacral placement. So we, again, indicated this patient for surgery and thought that she would make a good patient candidate for a CurvaFix. In the interest of time, just the final fluoroscopy, highlighting the inlet and outlet films of the CurvaFix implant in the upper sacral segment, avoiding the sacral neuroforamens and staying within the osseous limits. And we also elected to apply a retrograde superior ramus screw. Final postoperative film and postoperative CT scan, again, demonstrating safe placement of the CurvaFix implant. We also elected to fix her distal clavicle fracture to allow the patient to utilize the right upper extremity for transfers and mobilization. This is her 10-week follow-up. The patient was fully weight-bearing at the time with minimal pain to her pelvis. So these are two great case examples highlighting the ability for the steerable guide rod and the CurvaFix implant to navigate the osseous anatomy of the upper sacral segment in dysmorphic patients. And with that, I'll conclude. Thank you.